A very good afternoon to all, and thank you, Shalini ma'am, for having me here as a part of the instruction course. So today we are just going to have a look over the cataract and MIGS, and when we plan to do it together, what are the options and how feasible it is to go ahead with that. So before that, let's have a look over the prevalence of glaucoma, which is estimated to be 66.8 million by 2040. That's a huge burden. So in only if we correctly diagnose and intervene, we are going to prevent that blindness induced by cataract, glaucoma. And the core concept, because of glaucoma surgery and the glaucoma treatment, is not only about the slowing down the progression by lowering the IOP, it's beyond that. That's maintaining a good quality of life for the patients, and for that control of the pressures. We go back into the history, and when we look back in 1960s, trabeculectomy was introduced in the field of glaucoma management. Until then, it's been the gold standard of surgery till there was a new beginning, because with the changing technology and the customization of the era coming up, because it came as an early recovery. So there, the new beginning was in the form of MIGS, that's minimally invasive glaucoma surgery, which gave us a freedom and liberty of choosing the IOLs what we wanted to do with our glaucoma patients. Because before that, choosing the premium lenses used to be really a taskful job because of the astigmatism induced by the surgery. So now this gives us an option of choosing the presbyopic lenses as well. So if we want to understand the MIGS, we can understand them in simple 5 features. It's ab interno approach. It causes minimal trauma to the target tissue with a modest efficacy, but yes, excellent safety and rapid recovery with minimal impact on life. So the advantages is, like, if your patient doesn't want to use the medication and at the same time he is worrisome of getting some complications with the glaucoma surgery to be done, this is the midway where you can afford your patient a control of IOP, and that can lead to a better tolerance, improving the adherence. So if there is so much good about MIGS, then what is the actual debate? It's about expensive, and yes, it's still in mist, though we are having some trials now which are coming up with the I can say the results, but yes, the large RCTs are still awaited. Now coming to the options, if you want to just categorize the MIGS procedures, they are basically, you can start with the Schlemm's canal based, the subconjunctival filtration techniques, and the suprachoroidal drainage. And if you want to go ahead and choose the bouquet which MIGS is offering us today, let's have be a little practical, and what we are doing today would be the TM canal based procedures, mainly in the form of bang, KDB, which are the affordable ones, going with the eye stent, then eye stent supra. When we go with the MIGS plus, that is a bleb forming, that is this is a bleb forming procedure, that is we implant a Zen or a press flow, and last but not the least would be the ECP. So what would be the ideal choice when it comes to the cataract surgery? So alternatives, they do have a comparative results when it comes to the different MIGS. So if we talk about choosing to a correct procedure, let's talk about the angle closure. My previous speaker has made my job much easier, because it's we can definitely go ahead and do a MIGS procedure in a case of angle closure glaucoma, which is well substantiated by the literature provided. And as basically this video I have put, because what is important is placing the patient's head and tilting the microscope. That is, if you would have seen, I have placed I've tilted the patient's head 35° away from me, and I have tilted the microscope 35° towards me, and that makes my angle visualization much easier. With that, we start with this procedure, where this was a gentleman who was actually posted for phacotrab IOL, but he wanted a sutureless surgery, because he went through the literature and he said that he wanted a sutureless surgery. So this was amongst my initial MIGS procedure when I started, and I have purposefully kept this video, because you see the problems which we are facing, like after doing a phacoemulsification and implanting the IOL, we put the pilocarpine. you wash the AC, then you put the pilocup in, then you put a high molecular weight viscoelastic. Now cover the surface clearly, and now there is a placement of the swan Jacob lens. In the initial phases, I have kept some unedited part of the video so that the resident sitting here can benefit from it. See, this is visualization of the angle in the initial phase is definitely going to be difficult. The bubbles are there, there are corneal folds, so all these things are indicating that there is undue pressure which is being applied over the cornea. Now we put a iris spatula over that, and still the view is not clearer. So what we do is, there is a bit hyphema. So what we do is we wash the hyphema again and again, not getting worried by that, and then yes, you wash the hyphema, and then again you reintroduce the viscoelastic, and now you see the angle view is much clearer. And now with a simple tweak movement, what is a tweak movement? Like to release the synecdoche, you tap it and then you do sideways movement, and this releases the synecdoche. This causes the iris to fall back down. Here it's going, and see the movement, it's sideways as well as a dabbing movement which is releasing the synecdoche all around. So this we did for this case, and we never went for any bang or any associated mixed procedure for this case. And to our very surprise, the pressures, they came out to be 12, and we had started with 30 with a 0.85 cupping, and still the patient is doing well despite it's been, I think, 1.5 years I have been following this case. So this is just a learning video which I wanted to share. Now coming to the as I have already said that the RCTs are still awaited for the use of MIGS in PACG. But yes, when it comes to the MIGS, the first question comes in our mind is the affordability. So this bang procedure, that is the bent ab interno needle goniectomy, gives you the comfort of affordability, as well as you can start it with that. So there is not much of equipment which is required. So basically what you do is that you take a 25 gauge needle or a 24 to start with, whatever is available at your place. So to start with, what you do is that you visualize the angle clearly, and then you put a bent needle after duly filling the AC with a high molecular weight viscoelastic. Put some viscoelastic on the cornea as well, as we do in the OPDs. Now see, just put the tip over the TM, pick it up and just go ahead, and that's how your TM is being peeled off. And here, whatever the part of the TM was there which we peeled off, I'm taking out with the help of the forceps, so that you can do it clearly. And to overcome that, a more precise instrument had been launched in the field of MIGS that goes with the KDB, as known as KDP. And as you can see here, it has got two blades here, and there is a glide here, and there's a sharp tip. So with this tip you impinge on the TM, and there you just go. Simply it makes your work very simple, which we can see here in this video again. So after performing the phaco and implanting the IOL, you wash, put the pilo, constrict the pupil completely, and now again you put a high molecular weight viscoelastic, visualize the angle completely, and you see the difference, that how simpler and better it is, because now you can visualize the angle, as well as you can simply go, and a simple movement ahead in to and fro direction peels out the TM. So here you can see that cleft being formed, and in the other direction as well. And simply what you have to do is, now we join both the things together, and simply it takes out your TM. You don't have to put any extra forceps or anything to wash it out or to take it out, and with that we complete the surgery. So now there are stents are also there, though the affordability is a limiting factor for these MIGS procedures. But yes, again, it's a smallest intraocular implant introduced, and here you can see it that it is very well being implanted in the TM itself. This forceps goes and implants it there. So, covering this and having said this, still the match which is made in heaven is still awaited when it comes to combine your cataract surgeries with the MIGS, and the choice totally depends on the risk profile of the patient. Surgeon's skill, you talk to the patient, give him the options, patient's willingness to undergo repeat glaucoma surgery, and the stage of the disease as well. And what would we do when we plan to start a MIGS? Because I'm sure that everybody wants to start with the MIGS. So there are certain questions which you need to ask to yourself before start the MIGS procedure. Why offer MIGS? You can definitely tell your patients that for moderate glaucoma, that's a sutureless surgery which is going to help you with the early recovery. The skills what we need as an MIGS surgeon would be a good intraoperative gonioscopy. Which MIGS should you start with? So first would be the canal based procedures. Should you offer more than one MIGS procedure at a time? Definitely a big no for the beginners to start with. The suprachoroidal space MIGS, though not very good for the beginners to start with, but later on you can start doing it. With now, which MIGS should I offer to which patients? So answer to that is that for all the open angle glaucoma cases, you go with the canal procedures. And the most important thing is an informed consent. Please go ahead with the informed consent, and whenever you're giving a discharge summary to your patient, that I have learned from my personal experience, please write that an angle surgery has been performed. Now, pigmentation in the angle is really important to locate the TM when you are talking about doing a MIGS, and avoid MIGS if any inflammation is present. With that, we would conclude with a statement shared by Aiki, who is the father, I can say, of MIGS, who said that these are the devices or a procedure designed to address the treatment gap that exists between the medical therapy and more aggressive traditional surgical options. So definitely, to conclude, I can say that yes, definitely the MIGS is there in the field of glaucoma management, but we need to choose it wisely, as it gives us a twofold benefit in long-term cost utility evaluation. Thank you very much.
Thank you so much, Dr. Shweta, for covering MIGS wonderfully well and covering almost all types of MIGS and showing nice videos.